Our speaker is the chairman of the Department of Orthopedics, program director of the Adult Reconstruction Fellowship, Changhua Hospital, and a partner in the Cebu Orthopedic Institute. Past president of the Philippine Hip and Knee Society. Vice president of the Philippine Orthopedic Society for Sports Medicine. Fellow, Philippine Orthopedic Association, Philippine Orthopedic Society for Sports Medicine, and Philippine Orthopedic Trauma Society. Let us all welcome Dr. Jose Antonio San Juan.
The movement restrictions and isolation regulations imposed by the government during the COVID-19 pandemic has definitely taken its toll not only on the mental state of our elderly patients but on their physical well-being as well. Throughout this pandemic, we have seen a significant decrease in the amount of physical activity level involvement of our elderly patients, more so knowing that these patients could be suffering from some form of osteoarthritis. The reduced mobility definitely has not helped with regard to reducing their physical disability or improving their quality of life. Which is why we could probably try to look at other ways to maintain joint health, particularly for our active elderly osteoarthritic patients, knowing that these activity restrictions could hold on for an extended period of time. Recommendations from the different specialty organizations and international associations has mainly focused on addressing the acute pain episodes that most of our osteoarthritic patients suffer from. And this seems to be one of the shortcomings of these particular recommendations, because knowing the chronic nature of the disease, it is important that we do not only address the short-term symptoms that these patients present with, but knowing that it's a chronic degenerative process, we should include as well in our management some form of treatment to somehow decrease the disease progression over an extended period of time. Which is why the recommendations from the European Society for the Clinical and Economic Aspects of Osteoporosis, Osteoarthritis, and Musculoskeletal Diseases, otherwise known as the ESCEO, is a set of recommendations that's probably more inviting for most of us. Because not only does it consider the acute management of pain, but more so the recommendations also address the chronic nature of the disease and include in their recommendations some form of treatment that patients can administer to themselves throughout the whole duration of the disease progression. Moreover, these recommendations take into consideration the safety of these particular modes of treatment. The one good thing about this particular set of recommendations is that it actually puts into force a true multimodal approach to the treatment of osteoarthritis. So this multimodal approach not only includes pharmacologic management but non-pharmacologic management as well. As you see here in the core set, particularly for this particular set of recommendations, it actually empowers the patients to be part of their whole recovery and treatment process. So aside from the physicians being able to inform and educate the patients with regard to the nature of their disease, the patients are actually encouraged to get involved in a form of exercise that will eventually lead to some form of weight loss, which could decrease the disease progression over time and decrease the frequency of the acute pain episodes as well. Moreover, the first step in the treatment, particularly when it comes to pharmacologic treatment, not only includes management of pain, but then it also includes the use of systemic slow-acting drugs for osteoarthritis, potentially disease-modifying drugs that can slow down the progression of disease in the form of prescription-grade crystalline glucosamine sulfate. This is, of course, administered together with paracetamol in case there are acute pain episodes that these patients may experience. If the patients remain symptomatic despite this background treatment of the prescription-grade crystalline glucosamine sulfate and paracetamol, then this is the only time when topical NSAIDs could be added, and probably other non-pharmacologic forms of treatment, which includes physical rehabilitation, braces, or even insoles if there's any form of malalignment in the knee that could be encountered. So comparing the ESCO guidelines versus all the other recent guidelines coming from the American College of Rheumatology or even the Osteoarthritis Research Society Incorporated, International, you will see here that the ACR and the ORC guidelines use as first-line treatment already the administration of anti-inflammatory medications, whether they be in the form of your traditional NSAIDs or your coxo-selective inhibitors, whereas the ESCO guidelines uses as first-line treatment first the systemic slow-acting drugs for osteoarthritis like your prescription-grade crystalline glucosamine sulfate, together with the administration of rescue paracetamol with persistent pain, or even topical NSAIDs when both the Cisadoas and the rescue paracetamol prove to be inadequate. So it begs the question right now, how is prescription-grade glucosamine sulfate different? Now, as you very well know, expectations from the patients can oftentimes dictate their compliance to medical management. Now, I've encountered a lot of patients in clinic, and I suppose all of you have encountered these kinds of patients as well, who may have been prescribed glucosamine sulfate in the past, but have eventually discontinued the administration or the intake of the drug, mainly because their expectations were not achieved or were not reached. And when asking them, they will say that they were told that with the administration of the glucosamine sulfate, there will be some form of cartilage regeneration, which, as you very well know, does not happen with the administration of such drug. What this drug, however, does is that with administration of your prescription-grade glucosamine sulfate, there's some form of inhibition of the gene expression of joint degeneration mediators, which in turn somehow decreases the inflammatory process within the joint itself and slows down the whole process of cartilage degeneration, which means that we are not actually allowing for cartilage to regenerate, but we basically just slow down the whole process of degradation of the cartilage tissue. If these expectations are made clear to our patients, then the chances of them being compliant with the administration of this particular drug is expected to increase. Now, are there differences between the different forms of glucosamine available in the market? As you very well know, probably the one common form of glucosamine that's available in the market and easily accessible to a lot of our patients is glucosamine hydrochloride. Now, comparing your prescription-grade crystalline glucosamine sulfate versus the commercially available glucosamine hydrochloride, as you will see here, the concentration that you will see of the glucosamine sulfate that's available in the plasma of our patients is almost 3 times higher than those of glucosamine hydrochloride. And even the half-life of this particular drug that's available in the patient's plasma is almost 6 times that of the half-life of your commercially available glucosamine hydrochloride. So which means that the effect of the drug is expected to stay longer and last longer compared to your commercially available glucosamine hydrochloride. And as you will see here in these 2 particular studies that we're looking at the plasma concentrations, particularly of your glucosamine sulfate in the synovial fluid of patients after they were administered the prescription-grade crystalline glucosamine sulfate, it actually approximates what the expected effect will be when they reach the 10 micromole range, particularly after administration of the glucosamine sulfate over a 6-month period of time. Now, knowing that we are dealing with a disease entity that is chronic in nature, we should probably look at the effect of the administration of glucosamine sulfate or even your other pain medications like your anti-inflammatory drugs over an extended period of time. In this particular study, they were looking at the effect of your Cisadoas, your NSAIDs, your coxo-selective inhibitors over a 6-month period of administration in patients who were suffering from osteoarthritis, and particularly looking at the pain outcomes. And it was noted in this particular study that among the different Cisadoas, it was only the prescription-grade glucosamine sulfate that continued to have an effect at 6 months of administration. And even among the traditional NSAIDs and your coxo-selective inhibitor, it was only celecoxib that continued to have an effect as far as anti-inflammatory control is concerned over administration in a 6-month period. And of course, with continued decrease in the inflammation and decrease in the pain over that period, and knowing that this is particularly the chronic nature of the disease, as you might expect, it comes with a concomitant increase in physical function as well. So is there actually a true disease-modifying effect with the administration of your prescription-grade crystalline glucosamine sulfate, particularly in patients who suffer from knee osteoarthritis? One of the surrogate parameters that is being used to monitor the effect of your prescription-grade crystalline glucosamine sulfate is its effect on joint space narrowing. So in these two large randomized placebo-controlled double-blind 3-year trials on knee osteoarthritis, where two groups of patients were administered either placebo or a prescription-grade crystalline glucosamine sulfate, what was noticed here was that while there was still a noted decrease in the joint space narrowing in both these groups of patients, over 3 years, the absolute decrease in the joint space, the absolute increase in the joint space narrowing was actually higher in the patients who were receiving placebo compared to the patients who were receiving your prescription-grade crystalline glucosamine sulfate, which simply means that while joint space narrowing continued to happen in these groups of patients, the actual amount of decrease in the joint space was lesser in patients receiving your glucosamine sulfate compared to the patients who were receiving placebo. And like I said, while we do not expect that with the administration of your prescription-grade glucosamine sulfate would not result in cartilage regeneration, there was still cartilage degeneration, but then it actually happened over time in a much less amount of joint space narrowing in these groups of patients. So what is the eventual effect of this? So knowing that we have potentially a decrease in the amount of joint space narrowing for these patients, while it does not entail cartilage regeneration but continued cartilage degeneration with slowing down of the disease progression, we are actually able to delay now the need for a total knee replacement. Now this is particularly beneficial in elderly patients who may have a lot of comorbidities, for which their medical condition may still have to be optimized before they become good candidates for a total knee replacement. So knowing that we're dealing with elderly patients who potentially may have a lot of medical comorbidities, some safety concerns may actually arise when we talk to our patients with regard to the administration of glucosamine sulfate. So in this particular discussion, we're going to be focusing on 4 particular medical conditions. First, the effect of glucosamine sulfate on blood pressure, knowing that a lot of our patients may already be suffering from hypertension and that they may be on maintenance antihypertensive medications. The effect of glucosamine sulfate on glucose control or glycemia. The effect of glucosamine sulfate on patients who may already have a concurrent diabetes mellitus. And of course, the effect of glucosamine sulfate on the incidence of glaucoma. So to put it simply, in this particular study where they looked at patients who were either given placebo or your prescription-grade crystalline glucosamine sulfate over a 6-month period and monitoring their blood pressure over that period of time, there was no significant change in the blood pressure for the patients who were receiving your prescription-grade glucosamine sulfate. So kept simply, your prescription-grade crystalline glucosamine sulfate has no effect on the hypertension of your patients. Looking at its effect on glycemia or even diabetes mellitus, here again, over a 6-month period for which crystalline glucosamine sulfate at 1,500 milligrams per day was administered to these patients who may already have had some issues with regard to hyperglycemia or diabetes, it was noted that first, there was no interference with the glucose metabolism of these patients. Second, the administration of your prescription-grade crystalline glucosamine sulfate did not modify the plasma glucose levels of these patients, even if they already had a concomitant hyperglycemia, and that there was no significant increase in the glycosylated hemoglobin of these patients, which is, of course, the measure for blood sugar control, particularly in patients who already are suffering from diabetes. And finally, with regard to its effect on glaucoma, simply put, basically for patients who were either administered placebo or prescription-grade glucosamine sulfate, there was no noted difference in the intraocular pressure of these patients who may be suffering from glaucoma or not suffering from glaucoma just yet. So, in summary, looking at the algorithm or the recommendations coming out from the European Society for the Clinical and Economic Aspects of Osteoporosis, Osteoarthritis, and Musculoskeletal Diseases, or the ESCEO, where they actually recommend the early use of your systemic slow-acting drugs for osteoarthritis, particularly your prescription-grade crystalline glucosamine sulfate. For one, it was found out that basically with the administration of this particular drug, there is a noted downregulation in the expression of several inflammatory mediators that basically has two effects. For one, it decreases the inflammation that our patients may suffer from, particularly knowing that with the chronic nature of this disease, they could experience some acute inflammatory episodes. And secondly, with this downregulation in the expression of these inflammatory mediators, it eventually also leads to a decrease in the expression of your cartilage degeneration mediators as well. And with that, this eventually leads to a delay in the disease progression, or basically we're just slowing down the whole disease progression, which is inherent in this particular disease entity. And so now the use of prescription-grade crystalline glucosamine sulfate could be part of our first line of treatment in patients suffering from osteoarthritis, together with the administration of a rescue paracetamol, and only if these two initial interventions will lead to inadequate pain control, that's probably when we can initiate the administration of your other non-steroidal anti-inflammatory drugs or your COX-2 selective inhibitors. But what's most important is that with this particular background treatment as your first line of treatment, we know that these are fairly safe modalities of treatment that we can administer to our patients, knowing that we're dealing with elderly patients who may be suffering from a lot of medical comorbidities and for which safety is of primary concern as well. Thank you very much.
Our speaker is the past president of the Philippine Academy of Rehabilitation Medicine, founding president of Southern Tagalog Association of Rehabilitation Specialists Board of Governors 2014 to 2016 Pain Society of the Philippines, basic science lecturer, Philippine College of Occupational Medicine, recipient of Most Distinguished Physiatrist Award for 2021, Department of Rehabilitation Medicine, Philippine General Hospital. Alumnus, Department of Rehab Medicine UP PGH. Silver Jubilarian, UP College of Medicine Class 1996. Let us all welcome Dr. Michael Magabo.
We're going to talk about evolving concepts in back pain. Here are our disclaimers. So to start, definitions in medicine are conceptual frameworks on which we build up our understanding about clinical phenomena based on the weight of the most recent scientific evidences. Therefore, it carries nuances regarding treatments and prognostications. So let's talk about pain, a world in which low back pain belongs to. In the IASP 2022 general elections, the body voted to modify the definition of pain. It is expanded now by the addition of 6 keynotes plus the etymology of the word pain for further valuable context. The 6 keynotes are, number 1, pain is always a personal experience that is influenced to varying degrees by biologic, psychological, and social factors. Number 2, pain and nociception are different phenomena. Pain cannot be inferred solely from the activity in sensory neurons. Number 3, through one's life experiences, individuals learn about the concepts of pain. Number 4, a person's report of an experience as pain should be respected. Number 5, although pain usually serves as an adaptive role, it may have adverse effects on function and social and psychological well-being. And number 6, verbal description is only one of several behaviors to express pain. Inability to communicate does not negate the possibility that a human or a non-human organism experiences pain. The taxonomy of pain has undergone several iterations. Here we see pain as classified by etiology. The next slide defines the temporality of pain. There was also a year wherein the IASP focused on chronic pain, not only because it affects 20% of the living population, but also because it carries with it a more insidious prognosis. In recent years, chronic pain has been defined and categorized because of its implications on medical economics. So, in which chronic pain category will you put chronic low back pain? Low back pain as a chronic syndrome may be classified in IASP language as both primary neuropathic and or primary musculoskeletal chronic pain amongst other categories. In fact, different authors such as Jenkins in 2010 have tried to define low back pain based on its etiology. And of course, each clinical pattern comes with its own treatment regimen. Low back pain is defined as pain and discomfort localized below the costal margin and above the inferior gluteal folds, with or without referred leg pain. Although the term subacute pain is not accepted in the nomenclature of pain by the IASP, subacute pain is generally considered to be pain that lasts for 6 to 12 weeks. It is estimated about 10% of patients with subacute pain will develop chronic pain. I'd like to stress again that definitions are very important ways of contextualization. So important that the AAAPT, a consensus group on pain taxonomy, which includes inputs from the American Pain Society and the American Academy of Pain Medicine, lists down what the organization feels like the essential guide agreed upon by the three organizations regarding the taxonomy of low back pain with or without a limb component. If you notice, they define the same area as low back, aligned with all musculoskeletal specialties. And if you go through their criteria regarding how they define low back pain as such, the consensus group becomes very specific. Similarly, in fact, when you go through the CPGs of the Philippine Academy of Rehabilitation Medicine, we become very specific and even very selective in our language. This criteria, again, is similar to the CPG of PARM, though I say that PARM's is more comprehensive. Then again, you can just imagine how much discussion and debate went on first before this consensus criteria was published. Again, more consensus diagnostic criteria, this time with qualifiers, low back pain with neurogenic claudication. I'd just like to point out that the pain taxonomy group made an effort to list modulating factors related to low back pain. And these three areas are the listed. Can we go through again? Can we start with this slide again? I just like to point out that the pain taxonomy group made an effort to list modulating factors related to low back pain. And these three areas are what pharmacology targets for low back pain in attempt to modify them, such as anxiety and sleep. According to Flanagan in 2008, in his cohort of several hundred, wait, can we restart? The slide didn't move. I'd just like to point out that the pain taxonomy group made an effort to list modulating factors related to low back pain. And these are three areas that the pharmacology for low back pain attempts to modify, such as anxiety and sleep. According to Flanagan in 2008, in his cohort of several hundred low back pain cases seen in the OPD clinics, roughly 37% may have a neuropathic component to their back malady. Flanagan is the author of Pain Detect, a screening tool for neuropathic pain. Again, screening tools help clinicians detect the presence or absence of a neuropathic component of pain. There are those which are more sensitive than others, like the Leeds scoring scale and Flanagan's Pain Detect. Why is this important again? Romano's cohort of patients with low back pain screened and segregated to what is defined as predominantly neuropathic back pain or nociceptive back pain, but as clearly seen in the results, whether a low back pain syndrome is predominantly neuropathic, here with the lead score of more than 12, or is predominantly nociceptive, here as shown with a lead score of less than 12. A combination of a gabanoid and a coxib yields better pain relief than a gabanoid or a coxib alone. Definitions dictate treatment, and most noteworthy, it directs research. In this study by Taguchi et al., a cohort of Japanese patients with low back pain with a strong neuropathic limb component was treated with pregabalin, and the patient's scores improved. In this treatment strategy, do we find it lacking? Again, in this study, the author explores the use of pregabalin as a strategy for low back pain with limb neuropathy. He defines low back pain with limb neuropathy.
Recording in progress.
As a neuropathic disorder, hence his choice of intervention. But most authors consider low back pain as a mixed pain syndrome with both neuropathic and inflammatory components. Here are some reasons that try to explain the juxtaposition of the inflammatory component and the neuropathic component of back pain. IASP defines nociception as being the pain initiated or caused by the activation of peripheral nociceptors. It serves as an alarm and protective system against noxious stimuli. According to the IASP task force, neuropathic pain is defined as pain initiated or caused by a primary lesion or dysfunction in the nervous system. It is a pain in the absence of nociceptor stimulation by trauma or disease. So what is nociplastic pain? It is something not generated by the activity of noxious receptors nor by the activation of neuropathic pathways. It is caused by increased peripheral sensitization that in turn causes overstimulation centrally. It can occur primarily or as a comorbidity in chronic nociceptive or in neuropathic pain states. Besides a combined peripheral and central overstimulation, nociplastic conditions have both peripheral, like tender points, and central manifestations, like anxiety, and even associated features that can't be fully explained, like fatigue or non-specific vertigos. Now, do you recall patients with low back pain presenting with lumbar tender points then complain of so much pain during exacerbations that it causes anxiety, depression, or did we dismiss these patients as yellow flag patients? Think about it. Again, nociplastic pain may be a new concept in terms of pain mechanism and manifestation, but the strategies for treatment of its pain and comorbid conditions are the same. There are a wide range of drugs available, though some have more clinical studies than others. Most international pain organizations agree that the gabanoids are the first-line drugs for neuropathic pain. Tramadol and other opioids may be used for acute exacerbations of neuropathic pain, but not really as maintenance medications for neuropathic pain. There are drugs that may act as neuromodulators like polypeptides, keltican, or Hypacet, or even vitamins like methylcobalamin or cholecalciferol. There are 2 gabanoids presently available in the market. And though pregabalin, because of its pharmacokinetic profile, is the preferred molecule for neuropathic pain, there is no stopping a clinician if he decides to use the one over the other. There is a trend amongst FAMEDs and IMs to do combination treatment with various degrees of success. However, as of press time, this is not recommended. The rationale behind the combined use of the gabanoids is the difference in their pharmacokinetic profile. Since one is linear, acting immediately, the other has a parabolic nature of activity, hence of a delayed nature of onset. The concept of round-the-clock medications for neuropathic pain is not new amongst pain specialists. Pregabalin doses can be given in a maximum of 600 milligrams a day. However, if a patient's pain does not respond to a maximum of 300 milligrams given for 10 to 40 days, then another gabanoid or another drug class may be considered. Patients often complain of certain side effects with the gabanoids. More often, the clinicians forget to advise patients that the use of this group of drugs do come with these side effects because of the nature of their action. I think we should be worried if there are no side effects, if the drug is working at all. In my cohort of patients, if explained how the drug should work with all of its side effects, then patients complain less of the adverse effects because they have already anticipated these. Again, less anxiety because of familiarity. By managing patients' expectations, we define what adverse reactions truly are, and we define what we see as an improvement in terms of pain control. Again, the way we define back pain or any other type of pain reflects how, as clinicians, we consider their malady in their personal psychosocial context. Hence, treatment becomes not limited to drugs alone, but other methods that may be non-mainstream and yet are holistic, as our approach to pain should be. To the tune of $100 billion as an estimated cost of treatment for neuropathic pain. Well, we can't afford to be doing hits and misses with this. And in the local setting, when there is a lot of Me Too pregabalins, are we really doing our patients service by prescribing them a more affordable pregabalin na walang side effects? Again, let's go by definitions. Even when we are faced with the term bioequivalence, of which most generic pregabalins are claiming, knowing that bioequivalence is simply just a fraction of the total therapeutic equivalence that is expected of a generic equivalent, which in turn, in this country, unfortunately, has not been met by most of the manufacturers of Me Too generics. Pain, by its very definition, is both a very personal and universal phenomenon. Definitions and nuances regarding mechanisms, treatment strategies, and prognostications of pain and even low back pain are in constant flux because paradigms regarding pain are always shifting. Before, there was just nociceptive and neuropathic pain, with mixed pain syndromes being the intersection area of a Venn diagram. Now we recognize this new phenomenon as nociplastic pain. Treatment with the use of gabanoids is still first line of defense, and yet with multiple mechanisms that are simultaneously firing, mixed modalities may be more efficient in bringing down this type of pain to manageable and tolerable levels. Drug or no drug, our pain patients deserve the best possible pain strategies we have to offer. And yet, above and beyond these strategies, they have to know the truth regarding their pain state. It may not be the best analgesic, but it's the best foundation from where personalized treatment strategies may be initiated. Thank you very much, everybody, for listening. Hope to answer some of your questions during the Q&A.
Okay. Thank you, Dr. Juan and Dr. Magabo, for a very interesting and informative lecture. Now, the virtual floor is open for our two speakers to answer the question. Okay, for Dr. Someone. Doctor, which is more effective in preventing the joint spacing, the glucosamine sulfate or the glucosamine conjugating?
Good evening to everyone, and thank you once again for listening to the lecture and for inviting me to be part of this program. Now, it's not so much the combination, but it's more the molecule or the compound itself. So what's most important is that the glucosamine that you prescribe to your patients are actually the prescription-grade crystalline glucosamine sulfate. Now, it's actually more of the salt. So glucosamine sulfate compared to glucosamine hydrochloride, like I had shown in my lecture earlier, there's actually better synovial penetration and increased synovial concentration of your elemental glucosamine in the synovial fluid with the glucosamine sulfate rather than the glucosamine hydrochloride. So if you're talking about efficacy, we would rather go with glucosamine sulfate rather than glucosamine hydrochloride. As to the other components that could be added into the mix, take for example chondroitin sulfate or collagen or MSM, there isn't any evidence yet that actually points to any additional benefit to having all of these, because the main component that actually controls, that has some inflammatory control in situations where a patient's faced with an acute flare of osteoarthritis is actually glucosamine sulfate.
Somebody, thank you, Doctor. Somebody raising hand. Somebody's raising hand.
Yeah, I'd like to ask a question to Dr. Magabo.
Yes, go ahead, sir.
Okay, thank you, Dr. Magabo, for your lecture. My question is, typically for patients with chronic low back pain, not only do you have to deal with the neurobiology of pain, but as well as with the psychosocial repercussions of it as well. How do you address expectations? Because certainly with medications, it deals with the neurobiological aspect, but what about the psychosocial aspects, especially since the medications may not necessarily completely eliminate the pain?
Thank you for that question, Dr. Tofi. Again, with the present definition of chronic pain given by the IASP, we have to understand that the psychosocial framework also and the psyche of the patient is also important. We have to be careful about labeling a patient always as a yellow flag patient. Yung palaging nagre-reklamo. If I have a patient with a very strong psychological component to their pain, I'd rather refer to psych, because sometimes you may need to add medications that may elevate the mood, that might improve the depressed outcome. And I think that is already the specialties of psychiatry. And I do receive referrals for chronic low back pain or chronic pain from our friends in psychiatry so that I can do my physical therapy. However, these patients are already on psychotropic medication, whether they be single or multiple. And I think that is the answer to the question, because, it's not always the physical. Sometimes there is some psychological imbalance because the drugs up there in the central nervous system have already been, you have dopamine problems. You have a lot of other problems that I think is already falling in the realm of psychiatry. So I would rather have the patient be co-managed by psychiatrist, or even a psychologist, a clinical psychologist. I hope I answer your question. Again, we don't always label everybody as a yellow flag patient, because the IASP tells us
that it is important to consider the complaints of the patient as truth, because that pain is felt by him and nobody else. And I think when I lectured this to the rehab meds, I said that, we always dismiss everybody as a yellow flag patient. Maybe we would want to reconsider where we stand. Hindi naman lahat ng pasyente humihingi ng medical certificate. But there is pain. Right?
Thank you.
Sir.
Thank you, Dr. Magabo.
Thank you, Dr. Kobe and Dr. Magabo. Dr. Magabo. Doc, the long-term effect of pregabalin ba is to regenerate the nerves?
Sir, okay. With regards to long-term use, meron na po tayong latest recommendation ng American Academy of Neurology. They do not recommend the use of pregabalin longer than 3 to 4 months. Yan na po yung 2021 guidelines which was recently cascaded. Kasi nga po, they feel that it may have nephrotoxic effects. So nothing longer than 3 to 4 months. And that was recently cascaded in the guidelines of the American Academy of Neurology.
Okay, thank you, Doctor.
Yes, sir.
No questions on the call. All na Dr. Gracia for awarding of certificate.